All right, thank you for having me today. So today I'm going to be presenting on the vestibular migraine side of things. There's a lot of similarities from the vestibular migraine world with Havana Syndrome. So it'll be my pleasure to present to you about vestibular migraine today. A little bit of an introduction. I used to be at UT Southwestern, and Dr. Coots was is the neuro-otologist. I am the otoneurologist. So he's the otologist that deals with vestibular disorders. I'm the neurologist who deals with the vestibular disorders. These are my disclosures. I will mention some off-label use for medications today. Vestibular migraine is not a new condition. The diagnostic criteria for vestibular migraine was proposed within the last decade, but it is really an ancient condition. Even since the time of the Greeks, we've known that there is a relationship between migraine and vertigo, but this whole relationship was somewhat ignored for many years, and only started to pick up interest in the 80s, in the 90s, and now we are focusing more on vestibular migraine as a legitimate condition. It's the second most common cause of vertigo in adults and can affect up to about 3% of the population. It tends to affect women more than men. And if you look at the studies, there is a difference in the reported numbers. So it can range anywhere from 1.5 to almost 6 times more in women. It tends to affect people a slightly later age compared to migraine headaches. So in migraine headaches, it tends to affect the late teens, the 20s, early 30s, whereas vestibular migraine tends to affect people in the late 30s to the mid 40s. Often people who have vestibular migraine tend to have a history of migraine headaches and have a very strong history of motion sickness as well. It used to be known by many other names. So it was called migrainous vertigo, vertiginous migraine, migraine-associated vertigo, migraine-associated dizziness, migraine-related vestibulopathy, and benign recurrent vertigo. But now the preferred term is, of course, vestibular migraine. I think this also will help refine the research and our understanding into vestibular migraine. So vestibular symptoms and migraine, share very strong relationship. More than half of people with migraine experience some form of dizziness and vertigo. 2/3 of people with migraine have motion sickness. The incidence of benign paroxysmal positional vertigo, a condition where the crystals in your inner ear, they get loose and trigger vertigo with certain hip movements, is higher in people who have migraine. The incidence of Meniere's disease, or endolymphatic hydrops, is also higher in people who have migraine. In fact, half of people with Meniere's disease have some history of migraine. Another condition that will be talked about today by the great Dr. Starr, persistent postural perceptual dizziness, or triple PD, not to be confused with BPPV, is also more common in people with migraine. And another very interesting condition called mal de débarquement syndrome, or MDDS, where you feel this constant sensation of motion, feeling as if you're on a boat, swaying, bobbing, rocking all the time. It's also far more common in people with a history of migraine. And so the question then arises, if you have a history of migraine and you feel dizzy, or if you have a history of migraine and you have vertigo, does that automatically mean that you have vestibular migraine? And of course, the answer is no. So in 2012, Dr. Lampert and a whole group of neurologists and otologists proposed the diagnostic criteria for vestibular migraine. So a person has to have a current or previous history of migraine with or without aura, at least 5 episodes of vestibular symptoms of moderate to severe intensity, meaning it has to affect the person's ability to function. The episodes can last anywhere from 5 minutes to 72 hours. Now, the difference here is that in people with migraine headache, the diagnostic criteria states that it has to be 4 hours to 72 hours. At least half of these episodes have to involve at least one migraine symptom. And it has to be the headache, either with the throbbing unilateral characteristics and aggravated by routine activity, light and sound sensitivity, or visual aura. And of course, as with all diagnostic criteria, no other explanation. So then the question is, what sort of dizziness or what sort of vertigo does a patient experience in vestibular migraine, during the attacks? Then, in our studies into vestibular migraine, every single type of dizziness or vertigo imaginable can be experienced. And in this slide, I'm kind of a funny slide, but I like to use it because it illustrates the range of vestibular symptoms that a person can experience during an attack of vestibular migraine. Spinning is, one of the ones that people always think about, but you have many other different things. Some people feel as if they're flying, bobbing, swaying, rocking, feel as if the ground is shifting, they're sliding. All kinds of different sensations can be perceived as part of the vestibular migraine attack. Now, many other symptoms can also accompany the attacks of vestibular migraine. Headaches are, unfortunately not as common. So that's the interesting thing that now Dr. Coots mentioned earlier, the incidence of headache in Havana Syndrome is also rather low, and which is somewhat surprising if you compare it to TBI. In vestibular migraine, the range of freak headaches consistently reported with vestibular migraine attacks range anywhere from 25 to 75%. And this actually can throw off a lot of people. The diagnosis, remember, the diagnosis of vestibular migraine does not require the presence of headache, right? The headaches can be there, or they may not be there. And the absence of headache in vestibular migraine does not negate the diagnosis. I think that's the main important point to remember. The other features like, light sensitivity, sound sensitivity also can be used for the diagnostic criteria. Now, not included in the diagnostic criteria, but experienced by a lot of patients with vestibular migraine include osmophobia, or sensitivity to strong odors. The ear symptoms, although they are not part of the diagnostic criteria for vestibular migraine, are actually pretty common. In our case series at UT, we found that almost 2/3 of our patients experienced some form of hearing symptoms during their vestibular migraine attacks. Most of them reported some degree of tinnitus, ear pressure, muffled hearing. Some reported even ear pain or some very unusual sensations, some vibrating, bubbling, pulsating sensations inside the ear. And very non-specific sensory symptoms like vibrating sensations of the head, tingling, numbness all over the body, or even pain can be experienced as well. Now, here's where the link or the relationship with Havana Syndrome also comes into play. Neuropsychiatric symptoms like brain fog or trouble thinking, fatigue, emotional lability. So, you feel either, really depressed or, feel even euphoric, and even some very unusual sensations, what we call the Alice in Wonderland symptoms. So Alice in Wonderland symptoms refer to misperceptions or, certain illusions or hallucinations that occur as part of migraine attacks. Some people experience feeling as if they grow larger, feeling as if they actually shrink, kind of like Alice in Wonderland, or feel as if things in the environment grow larger, smaller, appear closer, appear further away. Some experience out-of-body experiences where, they actually leave their body, see themselves outside their bodies. Autonomic symptoms are also not uncommon, so having dry mouth. In fact, I have a history of migraine, infrequent, but I know when I'm having my migraine attack because I get a dry mouth. Some get, intense sweating, diarrhea, feel as if they get really warm or really cold. Excessive yawning is also not uncommon as part of the migraine. In fact, a lot of people experience a lot of yawning as a prodrome to a migraine. So it's kind of their warning that a migraine attack is about to come. Some get pale, some get the drooping eyelids, some get runny nose, eye redness as well as part of the migraine attacks. Visual symptoms, which are also pretty common in Havana Syndrome, are also extremely common in people who have vestibular migraine. Blurry vision, I hear that quite a lot. The feeling of eye strain. Visual snow is slightly less common, but it's a pretty remarkable, distinct symptom of migraine. So people, appear to see like little pixels in their visions. Everything looks a little bit pixelated, kind of like, static on an old TV. Some also experience double vision as well. So the end question would be, when do the vestibular symptoms occur during the migraine attack? So we have 4 phases of a migraine attack. There's the prodrome. So that can be about 1 to 2 days leading up to a migraine attack. The aura phase, which is about 5 minutes to 60 minutes before the migraine attack. The headache phase itself, the resolution phase, and then the postdrome. The postdrome is the part after a migraine where for 1 or 2 days you still experience some symptoms. And the answer is the vestibular symptoms can occur at any time during a migraine attack. Any phase can involve vestibular symptoms. And in some people, it may also not be as consistent as we would like. So some people may experience it, during the headache phase at times, and sometimes in the prodrome phase or even the prodrome phase, right? So, that can also lead to diagnostic confusion, unfortunately. Now, to make matters even more complicated, a lot of our patients with vestibular migraine symptoms also experience continuous symptoms. So, on top of when in this patient population, they have symptoms all the time, and superimposed on top of these constant symptoms, they have migraine attacks. And so in the persistent symptoms, a lot of them experience constant dizziness or vestibular symptoms. The lightheadedness, feeling as if things are, not right, kind of disoriented, as if you had worn a new pair of glasses. It's not uncommon to hear that. In fact, more than half of my patients report some degree of constant dizziness. Visually induced dizziness is also very common. So in this group, they will report feeling dizzy with certain things, like say if they look at, really ugly hotel carpets, if they look at anything with stripes, say if they look at the Venetian blinds, certain type of clothing, or if they look at objects that are moving quickly, say scrolling too fast on the phone, scrolling on the computer screen, or if you look at the TV and somebody's scrolling through Netflix, this Disney, Discovery, one of those channels. Head motion induced dizziness is also extremely common. So this is with dizziness that is provoked by moving your head too quickly. Motion sickness, also extremely common. And some people also experience what we call the paroxysmal vestibular symptoms. A lot of my patients describe these as the elevator drops. So they feel as if suddenly things drop, or they feel as if the ground is shifting very quickly. Visual symptoms also are extremely common. In fact, almost more than 2/3 of my patients describe some form of visual symptoms, even if they are not having a migraine attack. Light sensitivity is extremely common. Visual snow, less common. Blurry vision and eye strain are pretty common. Sensitivity to odors also is pretty common. A lot of migraine sufferers will tell you that they can smell things even before other people, detect them. Intractable nausea is not uncommon, unfortunately, and can be a very distressing symptom. Some patients also experience continuous headache, and in this group, it's important to distinguish other causes of headache. Could it be coming from the neck, occipital neuralgia, other problems, or even chronic migraine, a condition where people have headaches more than 15 days out of the month. Ear symptoms are also very common. In the interictal phase, noise sensitivity, a lot of patients experience that. Tinnitus, muffled hearing, ear pressure as well. Brain fog and fatigue are extremely common symptoms that I hear about in vestibular migraine. Anxiety, depression, insomnia also are not infrequently reported. In fact, about 70% of patients with vestibular migraine experience some form of anxiety. And in Dr. Teggi's Italian study, he went into a mental hospital and looked among the patients and found that, in fact, among those with depression, the complaints of dizziness was very low, but among those who who are admitted for anxiety, the complaints of dizziness were really, really high. Testing-wise, although there are no specific tests that can confirm the diagnosis of vestibular migraine, kind of like with Havana Syndrome currently, the diagnosis of vestibular migraine is made clinically. There's some non-specific abnormalities on testing that can be found. So, on VNG, you may see spontaneous nystagmus, gaze-evoked nystagmus. It can be central, it can be peripheral in pattern. You can have abnormal hip impulse tests. You may have abnormal caloric testing. You can find saccadic pursuit in a huge range of patients. And the problem with this one, I think, is also, cooperation and patient instructions. Some patients have vibration-induced nystagmus. So when you put a vibrating stimuli on the head, you can induce nystagmus. Some have positional nystagmus or hyperventilation-induced nystagmus. And now the interesting overlap with Havana Syndrome is that some patients experience abnormalities of the visual vertigo. So in my former mentors group at Hopkins, they did show that a lot of people with vestibular migraine have some abnormalities of the visual vertigo. Vent abnormalities as well, meaning indicating some otolith dysfunction, are not uncommonly reported in people with vestibular migraine. Now, I won't belabor this slide too much, but to recap some of the acute symptoms that have been reported with Havana Syndrome include the novel sound at the onset, ear pain, tinnitus, and of course our vestibular symptoms, unsteadiness, vertigo, dizziness, the headache, trouble thinking, nausea, head pressure, irritability. Again, there are a lot of similarities with vestibular migraine. The persistent symptoms, so once the acute phase is over and they enter into the persistent phase, a lot of patients with Havana Syndrome describe the following. They have headaches, vestibular symptoms, oral symptoms or ear symptoms, nausea, the visual symptoms, neuropsychiatric symptoms, and sleep disturbances. And again, looking at this slide and comparing it with some of the experiences of our patients with vestibular migraine, there is a lot of similarity here. So what do we think is going on? How do we tie the two together? So I think vestibular migraine can be incited by several different things. So the phenotype of vestibular migraine, the final, quote unquote, final diagnosis of vestibular migraine, I think many things can lead to that diagnosis. There is usually some form of inciting event. So a lot of my patients who end up seeing me describe some form of really bad stress at the beginning of it, or some form of hormonal changes. Either they had just delivered, or they're going through menopause, or depression, some serious medical illness. And more recently, a lot of people who have had COVID-19 infections, end up getting the symptoms of vestibular migraine. So what I think is happening is people who are genetically predisposed, you must have the genetics for it. And if you have some endogenous predisposition, say a good example, low vitamin D, low serotonin levels, I think some inciting event will eventually push you over the edge to getting vestibular migraine. So like, the ones that I commonly see, stress, hormonal changes, depression, medical illness, or even, getting infected with COVID, and also concussions. So in people who are predisposed to vestibular migraine, I've seen several football players, they have a history of migraine, they have a family history of migraine, and then after, some very minor concussions, develop the symptoms of vestibular migraine. And of course, directed pulse radio frequency energy. Could it be that, in some people who are exposed to such radio frequency energy, they may not go on to develop vestibular migraine? Possibly. Could a subset of patients go on to develop vestibular migraine? Of course. And I think it's not been mentioned yet, but an interesting suggestion from our colleagues in Canada suggested that possibly organophosphate poisoning could also account for some of the symptoms. And looking at the patients who had recovered from the sarin attack in Japan, and in some of the survivors of organophosphate poisoning, it is possible that some of these patients also could go on to develop some symptoms suggestive of vestibular migraine. Of course, we need to investigate this further. We need a lot more studies into this. We need to understand, do all patients with Havana syndrome have vestibular migraine? Obviously not. Do a subset have vestibular migraine? I suspect so. And so why does it matter? As the word syndrome implies, it is a set of medical signs and symptoms correlated with each other, but may not share a single identifiable pathogenesis. Several roads could lead to Rome, of course. I think it's important to distinguish Havana syndrome from conditions that are very similar to it, for example, triple PD, vestibular migraine, post-concussive disorder, or even the whole post-COVID syndrome, because that helps improve our research and data. If we lump everyone together, I think then the data will be more, difficult to interpret. A good example is with our patients with long COVID, right? If we are lumping every single person, looking at the timelines, right? So some use the 2-week mark, some use 4 weeks, some use 12 weeks to define post-COVID syndrome. In the absence of clear diagnostic data or clearly distinguishing who is from whom, we may not be able to, generate, much usable data. And furthermore, I think an accurate diagnosis can help refine and focus treatment, because like Dr. De Clever, Dr. Coote said, the ultimate goal is to help our patients get better. We want to understand the conditions so we can help patients get better. And if we look at vestibular migraine or migraine, and it's a busy slide, but just to show you, these are the treatments at our disposal today to help with migraines. You have the medical treatments, of course, like the old ones, like tricyclic antidepressants, the anti-epileptic medications, beta blockers, ACE inhibitors, the antidepressants, and the newer ones, like the CGRP blockers that have just been released. And then you have rescue medications, and a huge number of rescue medications that are available to us, the triptans, dihydroergotamine, the NSAIDs, anti-nausea medications, benzodiazepines. And interestingly, you also have the non-pharmaceutical measures. You have Botox, nerve blocks, SPG blocks. You can recommend vitamin use, many different therapies, tinnitus retraining therapy, vision therapy, neck therapy, cognitive therapy, vestibular rehab therapy, CBT, mindfulness training, and most excitingly for me personally is neuromodulation, using either vagus nerve stimulation or cephally device, the external trigeminal nerve stimulation, to try and help people with migraine. So the treatments for migraine, so many treatments are available today. I think helping identify who has vestibular migraine, who has migraine, is important because we can, bring these treatments to bear. Right. Thank you. Now we take questions. Dr. De Cleva will help curate.
Sure. Thank you, Dr. Beh, for a fine presentation. Because a lot of patients have tinnitus, could you comment on the use of, there are a lot of new apps out there to help tinnitus sufferers, as well as white noise machine and tinnitus retraining therapy. Could you comment on those things? Because they're becoming more and more prevalent.
Absolutely. So first step I always do with, I go through with my patients with tinnitus is to, send them to our colleagues in ENT to look at, if there's anything going on with the hearing and figure out if there's anything going on with the ears. Like Dr. Kutz mentioned, tinnitus is usually a problem of the brain. Right. So, but first, make sure there's nothing wrong with the ears. Some can benefit from using hearing aids. Some can, benefit from certain measures like tinnitus retraining therapy. The white noise devices definitely could work as well. There are medications that can also help in people who have, very intractable tinnitus. Most excitingly, I think, from the group in UT Dallas, was that vagus nerve stimulation seems to help with tinnitus. It can reverse the bad neuroplasticity involved in tinnitus.
Excellent. We have a question from Corey Leander, who thanks you for your presentation and asks, let me read it here. Is it possible for long-term suffering patients with vestibular migraine that you've spoken about, presumably in the more chronic phase of the illness, to cause changes in white brain matter volume or other brain structures?
So the white brain matter volume one is an interesting one. I'm not aware of any study so far in chronic, vestibular migraine where it shows that. I'm aware that in one of the papers reported in Havana Syndrome, there is reduced white matter volume reported. Now, it's not a very specific finding, but I'm not aware of it happening in, we're not aware of its occurrence in vestibular migraine. What we tend to see on just, plain regular MRI is, sometimes we get a few white spots there. What they call the, the T2 or flare hyperintense lesions in the white matter. A few spots here and there, are not uncommon in people who have vestibular migraine. I believe, some of the patients who in the Havana Syndrome studies also were reported to have a few of these white spots in the white matter.
Could you comment on diffusion tensor imaging? Because in the 2019 study, the Penn study, looking at 40 Havana patients compared with 48 controls, they found changes in audiovestibular pathways with DTI. Could you comment on that and whether or not you use that in your practice? Is it ready for prime time or is more research needed?
So definitely more research is needed there. We don't use that regularly in our practice because, again, it's difficult to obtain. It's I think Dr. Cullum can comment more on that, how it can be used, what the implications are. But I do, I think in the study, like you mentioned, there is reduced connectivity in the auditory and the visual spatial subnetworks. Now, and also in the cerebellar vermis. Now, could it also be like a little bit of a chicken and egg situation in where, if you have certain symptoms, then the brain, may reflect those changes, or are those changes in the brain the cause of the symptoms? I think that's a little bit difficult to tell. And, we definitely need more research into that.
There's another question for you, Dr. Beh, from one of our attendees, thanking you for your talk. And the attendee asks, he understands that the only definitive differentiation between vestibular migraine and Havana syndrome would be measuring energy exposure during those attacks. Could you comment on that?
So I will defer measuring the energy exposure to our colleagues who have more experience with Havana syndrome. What I would take away from it is this: the final phenotype of vestibular migraine, I think, can be incited by many different things. So you could get it spontaneously. You could be minding your own business, not being in an embassy anywhere. Could you still develop vestibular migraine symptoms? Many people do. could you have, kind of hit to the head, like in a TBI, right? If you hit your head, you get a concussion leading to the manifestations of vestibular migraine, most definitely, right? Could it still be post-concussive syndrome? I'll defer that to Dr. Barshikar's presentation, but there is a lot of overlap there. I think in a subset of patients who have Havana syndrome, the inciting event, the exposure to the energy was there. And although the insult is not ongoing, the changes that it had already produced may have pushed them into developing vestibular migraine already.
Thank you. Thank you, Dr. Beh.